Well, our next speaker is Dr. Neira, who we're very happy to have here from Buenos Aires. He was a professor at Favaloro University and directed the Career Specialist UCA Critique of Medicine. He was Deputy Director General, same, and serves on the advisory board of the Ministry of Health of Buenos Aires City. He was in charge of the Argentinian Society of Critical Care Medicine, the Pan American Trauma Society, and the Argentinian Society of Medicine and Surgery of Trauma. He's currently still involved and chairs the Trauma Foundation. He's a member of the National Academy of Medicine, the academic correspondent of the Royal Academy of Medicine and Surgery of Murcia. I hope I pronounced that properly. He's received numerous awards, including Doctor of the Year in 2007, President of SATI in 2001, institutional recognition of the Pan American Trauma Society in 2006, and the Master of Medicine in 2010. It's an absolute pleasure to have Dr. Neira talk about the Berlin Polytrauma definition, results from an Argentinian trauma registry.
Thank you, Nate. Thank you very much. Buenas tardes a todos. Quisiera primero expresar mi agradecimiento.
First, I would like to express my gratitude. We are pleased by the invitation from the Executive Committee to submit our humble experience. And number two, the city of San Diego has a special meaning to us because over 25 years ago, I met David Holt here. He's the director of trauma in San Diego in the UST Medical Center. He taught me two things. First, the commitment to the traumatized patient, and number two, the importance of data. Now, capitalizing on the fact that we have people from Canada, let me tell you that 25 years ago, I met Barrett Marlena and John Sampali when they were just beginning. Sandra also certainly met them when they were beginning the National Trauma Registry in Canada. And to me, that was a motivation to know what is happening, especially in the developing countries. Those data that we're going to submit and you're going to access very fast when it is in the U.S. or in the developed countries like Europe. To us, the example is the National Trauma Data Bank with millions of patients in the database of the National Trauma Registry in Germany with over 90,000. To me, that was the target to work in our registry. So in the year 2008, we began working on the National Trauma Registry. We began working in 2010, and this is a bit the experience that we want to share with you. The polytrauma definition is something new. You know that it is a Greek term that is not so used in the United States or Canada, but it is used in Europe and South America. And that is why this definition proposes a consensus on what it means. It is used a lot with the polytrauma, with the multiple trauma, with the major trauma, or major trauma according to the Hans Pape classification in the year 2000, taking an ISS higher than 18. And for that purpose, we review the local trauma registry. We did an analysis of results and had some future proposals. We need to define polytrauma according to the literature, and the definition were similar to multiple trauma, and that is the classification that Alston proposed of two cavities, two or more injuries, one cavity and two major fractures, or two or more injuries, one that is life-threatening in combination, or one life-threatening injury, major trauma with an ISS higher than 16, or the Hanover definition of an ISS higher than 18. Later, they proposed to add some physiological data, including the systemic inflammatory response syndrome, or SIRS, or the attempt to add physiological component to anatomic injuries. And there were some proposals, and the butcher took different centers and different surgeons and compared the definition of polytrauma, taking an ISS higher than 15, higher than 17, or 2 AIS higher than 2 in two body areas, and the agreement was low, and there was no agreement actually in the definition. For that purpose, we continue working with the work of Hans Pape, who also reviewed what we're looking at here, taking two significant injuries or more, taking severe injuries or any life-threatening injuries, and also the ISS that already were mentioned. The importance about the criteria to define electable patients were the ICU admission and multiple injuries, and the definition had to be performed at the hospital before the ICU admission. Who was supposed to define that? The best trained expert. That could be any professional trained in the trauma and ATLS or polytrauma course that is similar to the one that is offered in Germany. This population of the 90,000 patients that are part of the trauma registry of Germany has an average age of 43 years, 72% male, 97% blunt trauma, 93% admitted to the ICU, and the average ISS was 30 and the mortality 18.7%. This is interesting because the definition that was arrived, that is the Berlin Agreement, was two injuries with AIS equal or higher than 3 in two body regions, at least one of the following standardized pathologic conditions: age over 70, the GCS equal or higher than 8, the TAS lower than 90, the EB lower than -6, and the presence of coagulopathies, because the odd ratio was more significant with regards to the impact in the patient. The ISS was adopted because this is the more widespread severity score. The easy access to the lab SAMS was adopted instead of the inflammatory mediators assessments or any other assessment that was less frequent, and this consensus should help in terms of epidemiology for socio-economic purposes to quality control and educational strategies, and to easily allocate hospital resources in the case of the hospitals that are receiving those patients. In our country, the main cause of mortality, 10%, is due to external injuries, and the prevalence of external injuries is in the classical ages of 5 to 44 years of age, and that is in yellow. I cannot show this with a pointer, but in yellow you can clearly see the trauma patients with a much lower average age than those with cardiovascular diseases in red, or the neoplasms in blue. That is why in our country, like in many other countries, the years of age and work lost due to trauma is equal to the add up of the cardiovascular diseases and the oncological diseases. The trauma registry in Argentina, we designed it to be compared to the NTDB and the German trauma registry. It is codified with the ICD-10, the International Classification of Number 10 Diseases. It is mandatory in our country. That is why we have this classification. We use the AIS 2005 with the update of 2008, and we use the ISS, the NISS, the pediatric trauma score, the revised trauma score, the trees that we use for both, and for assessment at admission, the Bartle and the GOS. We have a team that is based in every hospital. We have also a central team watching over those teams. The information is included in a database, and we have an informed consent waiver, and that information is also delivered to every hospital. The hospitals, in total, 14 institutions, 12 are adult, 12 and 12 pediatric and two adult patients, and we have the hospital information. The definition was first the polytrauma definition according to PAPE that we already mentioned, and for the multiple trauma, two fractures of long bones plus a cavity or two cavities. We identify all the lesions with the AIS. We identify patients over 70 years of age, those with a blood pressure of less than 90 and a Glasgow equal or less than 8, but we did not incorporate the patient with coagulopathy or acidosis because we began in August 2015 following the PAPE definition of polytrauma that was published in 2014. So far, we have 21,542 patients in the hospital database and around 20,000 in the pre-hospital database. If we consider the patients admitted to the hospital database, 20,473, 1,423 in follow-up, less than 16 years of age, 5,500 other miscellaneous type of trauma, 1,456, and without AIS criteria, with an AIS criteria lower than 2, they were excluded. So 470 patients had two AIS higher than 3 in two body regions. Of those 470, 259 had at least one additional criteria like age, BP, or any other additional criterion, and 211 did not have any of the additional criteria. So when they did not have any criteria, the mortality was 19%, and when they had it, it was quite higher, and it was 46%. To the left, you can see the average or median range of age, 29 years. The male gender, for the male, 81%. For female, the median age was 40 years, and for male, 26. That was clearly significant. That's the mortality according to the physiological additional criteria. But in some cases, like the KPTT or the BE, the numbers were different because it was recently incorporated. We look at the polytrauma patient, and there was a higher number of motorcyclists than general population that had an equal frequency of injuries of motorbikes or assaults. But however, in the polytrauma population, the motorcyclist injuries are quite frequent, especially in South America. It is quite often, and in Central America, they use the bike as a transportation, as a means of transportation, much more so than what you see here in North America or Europe. The 78% of patients presented some degree of instability at admission, and in the case of patients who die, like you can see in the chart below, it was significantly lower than patients that did not die. The ISS was certainly higher in the survived patient, 26.2 in the survivors, 30.6 in the non-survivors, and the NISS, which is similar to the ISS but with two injuries, it was higher in the non-survivors with 35.6 versus 30 in the survivors, and that was statistically significant. In the probability of survival, estimated by TRIS, it was lower in the non-survivors, and it is interesting to see that the mortality adjusted by injury was slower, and when you want to explain it, the polytraumatized patient, they had injuries in the head. 34% of patients had a trauma in the head, 23% had injuries in the chest, and 50% in the limbs, and that is what generated the higher mortality. The non-survivor patients show a significant lower mortality because there was a high initial mortality because many of the patients died within the first 24 hours, and this population that died because of the severity of the lesions. As you can see here, we separated the injuries from 1 to 5. Only 0.8 was of indeterminate severity. It is interesting to see that we have indeterminate severity in a developing country. And clearly you can see the distribution of the IAS. That was 41% in the total number of injuries. In this chart, a bit difficult to understand. You have to look at the dark blue that shows the prevalence of injuries of AIS3, initial injury. 283 patients had a head injury, 204 in the thorax, and 96 in the lower extremity and pelvis. When you compare the polytrauma to other definitions, we had 259 patients with polytrauma, and if we take into consideration the multiple trauma definition, it was 808 and 2 patients, ISS higher than 16, 1,349 patients, and with an ISS higher than 16, it was 2,143. This is very important because when you compare a major multiple trauma and polytrauma, though they look similar, they don't have much to do. Clearly you can see the differences when you analyze the 3 or the 4 causes of the definition. The mortality of the polytrauma was 46%, significantly different from the multiple trauma, or with the ISS higher than 16 or an ISS higher than 16. For those with an IS 3 in the head, they also had a higher frequency of 75% in the polytrauma, and the survival adjusted was significantly lower in this group. When you look at the 100% of the polytraumatized patients, they had an ISS and an ISS higher than 16, but 85% of patients had a multiple trauma, but only 28% of multiple trauma patients had polytrauma. Only 30% of multiple trauma patients had an AISS higher than 16, and the same for the ISS. So the difference that is significant the significant difference was in the injuries of motorcyclists. The group of polytrauma was more significant, and in the assaults that was significantly lower in the polytrauma group. When you compare the multiple trauma versus the isolated trauma, we have an ISS higher than 16. The multiple trauma patients presented a higher ISS than the isolated trauma patients. The similar physiological compromise, however, the patient with an ISS higher than 16 had multiple trauma patient presented a similar RTS than isolated trauma patient, and this is due to the severity of the head trauma. To us, the sensitivity was low in this case. Like in most cases, the specificity was a bit higher for the polytrauma group, but lower than the ISS and the NISS, and the positive and negative predictability factors had similar rates. So with that, we can conclude the Berlin definition of polytrauma allows the identification of those patients with a higher risk of death, as you already saw. However, the global performance of this definition does not overmatch the definition of major trauma, and due to all accessory elements that show some impact, an additional way to improve performance should incorporate a differential weight factor for each of one, so that this definition could have or could offer more clarity in the prognosis of the polytraumatized patient. And what we are proposing is to develop this randomized multi-center studies. We already spoke with Rubiano a few hours ago that these experiences from Latin America make necessary the need to have our own information to be able to have a benchmarking with two important registries like the NTB and the Trauma Registry and from Berlin, and that way we can know what's happening in the developing or developed countries with regards to the different standards as you have seen here, and that is going to tell us what to do, but we also need to do how the patients are doing when we're performing this in our countries. Thank you very much. Muchas gracias. Una presentación fenomenal con un trabajo increíble. ¿Alguna pregunta de la audiencia? Vamos a verificar en línea. Bien. As, as we wait for the questions, I would like to talk about the importance of the Argentinian registry and if it is possible to know about your future plans, government level. What are the comments and what examples you could offer to other regions in the Americas or to other low-income countries? Thank you very much, Andres. We are at a developing stage and dissemination stage. We have developed the registry in a single province, but we have 24 provinces, and our proposal is to reach the 90 hospitals nationwide. That's what we're working on right now. We are working with the government to see if we can disseminate this. And number two, having a registry is absolutely possible. The local development of the registry should include similar criteria. It is very important for benchmarking to compare data. Maybe for you in a developed country, this seems simple, but in developing countries, this is much more complex. But it is absolutely possible, especially to compare the registries. The most important thing in our countries is to achieve a sustainability over time of those registries because we have the funds to achieve it. This is not a minor topic. This makes things more complex when we work in our countries, but it is absolutely possible. We're working, and I'm going to show that tomorrow in a quality control program that we shared with the WHO a few months ago, and Felipe and Andres were part of that. And we think it is the only way to have quality control, to know what's happening. And in order to do that, we need to have proper data. That's what we give so much importance at the data registry. Thank you very much, Doctor. Thank you.